So we've talked about how you got involved in the field of MCH and some really fantastic stories about almost seeing sort of the worst of the sort of the chaos and how people are treated badly and bad practices and then some really nice models that have evolved and certainly some of them you've provided the leadership for, but you've also had this opportunity to get involved in some things because of other both the times were right and the people were right. So if you were to talk about kind of what were the opportunities or what do you think about for emerging MCH professionals and emerging leaders? What kinds of elements do you think are important to help the field move along? I mean, there are so many challenges to us to help women and children and families. If you were going to talk to students and new professionals, what kind of things would you like to see us put together in terms of skills and policies? I know that's a broad question, but looking at your career, what helped the most? What would you like to see other people get?
Well, I had, after I'd been at Gainesville about 10 years, I was approached to take a sabbatical and go up to the state health department and write, because we already had a really good program throughout the state to take care of sick babies, the Children's Medical Services program, and then that started including high-risk mothers. But we had, most of the counties had no basic prenatal care, except the counties under the MIC project, which were Miami, Fort Lauderdale, Palm Beach, Orlando, and then the Gainesville area. Those were the only places basically where poor people got comprehensive prenatal care in this big state. So the pediatricians actually, after a number of years of the CMS program, said, we got to stop the influx. We're getting overwhelmed. You know, it's the thing about stop throwing bodies in the river. And so they said, we got to get somebody up here to deal with the pregnancy problems. And so I was invited up and I spent a year in Tallahassee. A bunch of us from around the state, we wrote a 5-year plan. And it was mostly policy. Here's what we need to do. Poor people need childbirth education, so we started an outreach childbirth education program. We need far more comprehensive family planning available than we have. Every county needs to be able to, and the only model we could come up with was to have the county health departments provide the prenatal care, which was the model we were using around Gainesville. Let's do that in all the counties. To do that, we needed money because the Gainesville project was federally funded. So we had to come up with this plan, present it to the legislature, and get it funded, and they funded it. But the one of the ways that we convinced them to fund it is I made a slide to show to them saying that if you'll fund this to the tune of about $8 million, in 5 years we will reduce the low birth rate by 50%. Fortunately, most legislators have very short attention spans. We didn't make a dent in the low birth weight rate. But on the other hand, everybody started getting prenatal care. And so the other thing from a policy standpoint that we did is we had all this data sitting up there and nobody was using it. MCH has the best data of any part of public health.
Absolutely.
You know, pregnancy lasts 9 months and then you see what happened. So we all started, you know, actually Dr. Sappenfield, who was at CDC, helped us figure out how to start using our data effectively. Before that, we just sort of made stuff up, and our data was better than theirs because they didn't have anything. But from a policy standpoint, using data effectively is amazingly important. Even though we have some anti-scientific politicians, most of them will ask you, show me,
Right.
And then the other very effective part of data is the health management part of it. What are you going to save them? Because some politicians will help you out because it's the right thing to do. Some will help you out because it's going to save a bunch of money. I'd say the best are right in the middle somewhere, but you got to deal with both issues. And so we're very effective at doing that, and I mean we in the big way, because we established the Florida Healthy Mothers, Healthy Babies Coalition, which was interested people from around the state, not necessarily professionals. Many of them were. And we selected people from various groups, like the OBGYN Society. Instead of calling them up and saying, send us somebody, because I'd been on their committees before, and there are professional committee goers, we'd say, send us Dr. Jones from Ocala, because we really know he'd be interested in this. And Dr. Jones would come and he'd be engaged, and he was with it. And so those people really made a big difference when we went to the legislature and the governor, because they were all behind it.
Right.
So it's very hard for one person to make a policy change. You need a group of people. The other thing that you need is, if you're going to do something really big time, it may take you 2 or 3 years to get something big through, and you can't give up. You just got to be persistent. And then people need, another skill people need to learn is presentation skills. How do you present something in 3 minutes? Like they say, the elevator speech. People should be trained in, if they're going to be running an agency or helping run an agency, in ambush interviews.
Describe that.
How do you deal, you're walking out of a committee meeting or somebody, and the press jumps in front of you and says, you said this in there, prove that that's for real. And you will, so I think those are all great skills to have. For people that want to be leaders in MCH, I think you have to learn to be better public speakers. There are things like Toastmasters and other clubs you can belong to where you can improve your skills. My kids used to make fun of me, and I'm catching myself doing it here, is that I would say every other word, and they just started making fun of me about that. So that I didn't kill any of them, but I did try very hard not to keep doing that.
You're pretty good at not doing that. What do you think? Think of someone you really respected in the field of MCH, and what do you think those elements are that make a respected leader, or
Well, there are a lot of people. I think of my contemporaries, I think Dean Peterson is a good example of somebody who's a consummate MCH leader in the modern era. She, is well trained, well read. She really does a good job of engaging people. She deals with issues head on. She's very straightforward. I don't think I've ever heard her give anybody a bunch of blarney about anything.
Right.
And I think those are all, she's just a really good example for students to emulate. But I also think it's good to, when you're in training, not necessarily stay in one place. When I was going to medical school, I was in Morgantown. West Virginia had had a 2-year medical school for 75 years. The dean was a friend of our family. I was accepted. I went to interview. He called me in for an interview. He said, "I really want you to come here, but you should not do that."
Wow.
He said, "You should get out of Morgantown. You've been here all your life. Go to different places. Everything's done differently around the country."
Great advice.
Oh yeah, and it absolutely was.
Yeah.
So I've been all over the place.
Yeah.
And it helps you deal with Florida because Florida's all over the place.
Florida's a challenge.
The state
Yep.
is like 5 different countries.
Mm-hmm.
But at each place, I mean, you know, when students are talking to me about going to a place like what's her name that went up to study with Jean DeClercq? You know, I want
Jordy went up, right?
Jordana.
Right.
I really wanted her to stay here, but then I thought, well, you've been here.
I felt the same way.
Yeah,
I did.
and Jean's just such a gem to deal with. Well, he's a great leader. I mean,
Yes.
and you can learn so many things from him
Mm-hmm.
as to how to convince people to change policy.
Right.
You know, those things that we see in class of his presentations are masterful as far as using data in an effective way to change policy. And I think the other thing that made a big difference was working with Governor Childs as learning from him as to how you get other people to do things is almost becoming a lost art, and that is you try to be as friendly as you can to the opposition. You try to make friends with them. So that they know you as a person and not as an opponent.
Right.
And he was very good at that, and people nowadays are getting so polarized,
I agree.
they don't think they can do that. But actually Benjamin Franklin, in his autobiography, which I think everyone who wants to be a leader should read, you know, how to win an argument, and it's not by calling the other person a jerk. The other thing I learned from Governor Childs and other people in politics is never go in to an important meeting about policy without knowing how it's going to come out. Which means if you're going to go in and try to convince 6 committee members to do a change that you want done, you should have met with all 6 of them before the meeting and tried to convince them to be on your side. And then if there still are a couple that aren't in the committee meeting, the ones that are on your side can help convince them, so it's not you doing it.
Charlie, talk a little bit about working with Governor Childs and that time that, so you were at UF and you did that sabbatical up in Tallahassee, and that led to sort of the next phase of your career. Talk a little bit about being in Tallahassee.
Yeah, actually, when I started working in 1982, we were at the bottom of all the states in infant mortality, and so that was the big challenge. And we did the 5-year plan, and that involved a lot of stuff, including the coalition. And so they asked me after my sabbatical was over to be the ATMCH director for the state. So I had a busy life. I'd lived in Gainesville. I'd drive the 3 hours up to Tallahassee or wherever they wanted me to go that week, Miami or Key West or whatever, and tried to keep my practice going on Fridays, and that went on until 1988 when Governor Martinez was elected governor, and the Florida Medical Association and Governor Martinez asked me if I'd direct the state health department. And I had, all my life I've fallen into these things. I had no, this was not pre-planned. So I talked to my family and agreed to do that. And so about 2 years into that, Governor Martinez was not reelected. One of the main reasons was because he tried to torpedo the state abortion laws. 85% of Floridians didn't want them touched. But he's still a good friend. And Governor Childs was elected. Now, I'd worked with Governor Childs for a number of years when he was in the Senate, because he established the National Commission on Prevention of Infant Mortality. And I went around the country with him doing hearings on infant mortality, mostly throughout, I went with him throughout the South. And in the couple of years when he dropped out of the Senate, he was coming to see me all the time because he just wanted something to do. So we got him involved up in Quincy because the infant mortality rate was so bad up there in the black community. And he then, after working up there, because he and Mrs. Childs were so interested in pregnancy and children, he just got antsy and decided to run for governor. And so we were all happy about that. And of course he got elected, and I was already working there and running the state health department, and he asked me to stay on. When a new person comes in, everybody's asked to resign, right, and then they pluck back whoever they want. So we already had a nice close relationship, but we were already making a lot of progress in infant mortality. We'd gone from last to 30th or something like that. Mm-hmm. And because we were doing a whole bunch of things we hadn't done before. And so
what kinds of things?
Well, we'd expanded the WIC program to all counties. We family planning, training more midwives when we had a doctor crisis. The coalition was one of the biggest. Prenatal care in all the counties that we hadn't had before. Mm-hmm. So huge change. And I was feeling pretty good about where things were. Governor Childs says, no, we need to do more than this. And that's where the Florida Healthy Start came in. And that expanded children's medical services. We now have high-risk screening for all mothers and babies. We're the only state that does that. And a couple of other things. Oh, it increased payment to doctor and midwives, so mm-hmm. more of them would participate. The biggest thing it did was establish the coalitions around the state.
Right.
And that was Governor Child's idea. He said, you know, Bob and Adele Graham were interested in seniors. They did so much for seniors around the state. Governor Graham leaves office and all those programs go away. He said, I don't want these programs to go away. And I think the way we can keep them going is with local coalitions.
Mm-hmm.
And, you know, my friends around the country said that never works. Don't even bother with it. And I said, well, Governor wants it done. And so USF and Dee Jeffers and Doris Barnett really went around the state helping the coalitions get established. They had to learn how to use data
Mm-hmm.
and how to talk to politicians and so on. And the March of Dimes was a big help. And, you know, to this day, they are very strong. And considering some of the administrations we've had since, you know, we're still in a hole, but we wouldn't be in as deep a hole
Right.
if the coalitions weren't there protecting us, because they go to the local politicians
Right.
and say, don't you touch our money, because here's what we're doing in this community.
Mm-hmm.
And one of the best is here in Hillsborough. It's really fantastic. So I think that's one of the biggest things. Well, another good example was one of the biggest things we did was to get the county health departments, who in this state are state-run, to actually get out there and let the community be involved. And at first, many of them hated the Healthy Start coalitions because they felt they were nosing into their business, which they were. It's another group to be accountable to.
Right.
You know, we were doing just fine. Well, maybe not. And here come these uppity women and whoever else is on the coalition demanding us be accountable. And another good example of teaching the health departments that they had to work with the community was back in, you know, Governor Childs asked early on, why is our childhood immunization rate for 2-year-olds stuck at 63% for the last 10 years? And we had good people at the state in immunization, but we just weren't getting the job done. And Dr. Bleckman, an internist in Miami that I'd met, had just stepped down as president of International Kiwanis, and we knew that they were interested in children's health issues. So I called Will up, and he met with Governor Childs and I said, is there any way you can think you can help, Kiwanis can help us with this? And he went back to them and he came back and said, we're going to take this on as our main project for the next 10 years. And it was amazing what they did. Well, again, some of our folks at the state and at the counties, here are these businessmen coming in the county health department poking around saying, how do you keep track of how many kids you've immunized? Well, we don't have any way to do that. Or we have a card file. And they say, why don't you use computers? Well, we don't have any. Well, we'll buy them for you. Well, we're in this Polk County. It's a big county. It's hard to get out to all the rural areas. We'll buy you a van.
Is that how you got involved with Kiwanis?
Yeah, I'm in Rotary, but
Oh, that's right. You're in Rotary. That's right.
yeah, but
I didn't know that.
we knew Kiwanis. You know, Rotary works worldwide to eliminate polio, so
Right.
I've worked
That's
on
right.
that. But Kiwanis works with children's issues, and
Huh.
so they took this on, and but it really made a lot of our folks nervous. And I just said, Governor Childs wants Kiwanis to work with us. We're going to work with Kiwanis.
Mm-hmm.
And it Within 2 years, we were up to almost 90%.
Really?
They did all sorts of things. You know, the ones in Miami said, we got all these undocumented people down here and all these recent immigrants. You know, we've got outbreaks in the Haitian community of diphtheria. Let's get all these kids immunized, you know. Well, how do we do that? Well, somebody thought, most of them are Catholic. Let's get the churches involved. And a lot of the illegal folks or undocumented folks are afraid to come to the health department because they're afraid they'll be turned in to immigration. So they'll come to church, and if the priest says this is okay, they'll get immunized, and they did. And so they just thought of all sorts of ways our folks hadn't thought of, but then they learned, you know, these are good ideas.
Right.
And you know, it was really interesting because it's very hard to get younger people to join service clubs today because they're too busy. And the whole idea of service clubs is to promote business in the community and provide service in the community by doing that. Our Kiwanis Club in Temple Terrace just closed down because they couldn't get enough members. I would go, after we worked with Kiwanis for a year or so, they'd invite me to Union County or someplace like that to dedicate a van. And they just wanted me to be there. So I'd go down, I'd say some good words thanking them for raising all the money for the van. And invariably they would come up to me afterwards and say, no, we thank you guys, because if we didn't have this project, we would have folded by now. This was our reason for living.
Really?
Yep.
Oh, that's great.
So, you know, I hadn't even thought about it that
Sure.
way, but it worked both ways.
Sure.
So so, you know, when I arrived here as dean in 1995, this college wasn't engaged with the community. I mean, in any meaningful way.
Right.
And now, you know, and the community told us that.
Mm-hmm.
Hey, your professors come out here and do studies
Right.
here in East Tampa, and they don't ask us what we want studied. We go along with it, but then they never come back and tell us what the results were.
Right.
So we're not going to do it anymore.
That's right.
So it took a number of years to rebuild that trust.
Mm-hmm.
And you know, being on the boards of the coalition, other community boards, you know, it's just like in the last 10 or 15 years that public health schools have learned the thing about community-based research.
Right. Right.
And it's been a tough sell to the faculty. One of the reasons is that we had not had very many practitioners on the faculty that had ever been to a health department. And so why shouldn't, you know, what would doctors and nurses be like if they didn't work in hospitals as students?
Right.
Well, our students now go out and work in health departments, and that's the way it ought to be.
Mm-hmm. What do you think, from your perspective, starting in the hospitals in Chicago and Minnesota to Florida to UF up to Tallahassee, and then you were the dean here of the college, and then on the faculty here and teaching and involved in so many of these coalitions. And so you have this perspective across these decades. And now we're looking at the Affordable Care Act and what that may mean to Americans and what that may mean in terms of public health at MCH. What do you think the future of MCH is, and what the next set of issues are that we need to deal with?
Well, I think it's huge. If that hadn't passed 5 years ago, just looking at these issues we've talked about in healthcare practice, just in OBGYN, I said things were, in the practice community, were worse than I'd ever seen them in 40 years.
Really?
It was really bad. Very money-driven, a lot of crummy patient care, people ripping off the Medicaid and Medicare systems and going to jail or running to another country. Doctors have dropped in esteem from the top down to the bottom. They're just above politicians. And but I think there's just a lot of hope now. I think I was president of the Association of State and Territorial Health Officers when the Clintons were trying to get health reform going, and they involved us a lot. We went to a lot of meetings with Ira Magaziner and other misdirected people that were very brilliant but not so smart. Public health, by the time they had spent a year or so working on it, was just out of it. You couldn't even find it. And we'd complain, and they'd say, oh, we have a public health nurse working in a room right down there. But the prevention wasn't in that. Mm-hmm. So it was a good thing it failed. I think it was way overblown. But I think there's a lot more public health built into, and prevention built into what's coming. Mm-hmm. And I think it's really exciting. I just wish I was 30 years younger. The the opportunity for prevention is going to be huge. I think if I was in health policy and management now, I'd just be salivating, because the only way we're going to be able to pull it off is for HPM specialists to show how much money we're wasting, where the graft and corruption is, and getting these bad practices under control. Mm-hmm. So, and I just, on NPR coming in here, I heard about they're clamping down on hospital readmissions. You now get penalized if you have too many hospital readmissions. This is a boon for the pharmacy industry, for the pharmacists. And Walgreens is jumping in to this whole thing about, you send those patients to us right when you send them home. We will sort out their meds and make sure they understand these new meds they're on for heart failure or whatever. And that's a great place for Walgreens to hire health educators.
No kidding.
They're already hiring nurse practitioners. Walmart, Walgreens, all these places could have health educators in there, and the hospitals could help pay for them to prevent readmissions. Because a lot of readmissions are medication errors or things along that line. So you can look all over the landscape and see huge opportunities for public health. In MCH, you could use that as a microcosm of a lot of that. Cancer prevention and prevention of overuse of technology. And I must say, the American College of OBGYN, I was really hard on them 5 or 6 years ago. They're coming around. They see the handwriting on the wall, and they're coming around to say, yeah, we are doing too many cesareans. We are, and they're putting that in their education. So I think for the MCH students coming out, healthcare reform is really going to need people that are good at developing programs, implementing programs, doing community-based prevention research to show how much money could be saved, because Americans are bad preventers,
Right.
and that's going to have to be built in to the whole new system that, you know, if you don't want a big copay, you're going to have to stop smoking.
Right.
I just think, I can't think of an area, you know, I'm glad we're restarting our nutrition program here, because
Right.
there's so much we don't know about nutrition. You know, alternative medicines are being used by so many people. Some of them are good, some of them are dangerous. We don't know which.
Right.
And that's really population-based research.
Absolutely is.
You know, to find out anything about whether a supplement such as CoQ10 or anything like that really works. We think it does. Seems like it ought to, but you know, that kind of research is very complicated, but we need to figure it out, because that's going to be, pharmaceuticals are probably our biggest expenditure in healthcare, and that's part of what public health needs to be doing, is big epi studies
Right.
on drugs. You know, maybe reforming prenatal care. We've talked about that before. We tried that a little bit. Does somebody with modern, somebody who lives in a rural area, do they need to travel to have a prenatal visit? Or could that be done on Skype? It's easy for people to take their own blood pressure. They could even be given a Doppler monitor to listen to the heart rate. Of course, even that's superfluous, because if the baby's moving, you don't need to listen to the heart notes. There are just so many things we could do to cut the cost of care, get people more involved in their care.
Right.
And maybe people that are generally healthy could have 2 actual face-to-face prenatal visits before their birth. You know, some people would like that, other people would want to come in and see a
More,
person,
right.
but
Right.
that would be their choice. You know, places where people, I mean, I'm always thinking about rural health, because that's the hardest part of public health, is how do you take care of people in rural areas. Somebody once said that if you elect to live in a rural area, you elect to not have a whole lot of services that you would otherwise get. With modern technology, and Dr. Curran and I have talked about this, the military seems to be able to handle a lot of these things from a distance. If you're stationed in Antarctica, you can get care
Right.
long distance. Why don't we do that for other people? There are just a million things you can think of that we could improve care.
I know.
You know, all that good stuff we did in Florida is sort of leveling out, because what we didn't build into that was an inflation rate. By that I mean population inflation.
Right.
When I left office, we had 186,000 births a year, and now I think Florida has 225,000. Well, we still have the same level of services we had back then, and that's cramping the system. still trying to think of MCH things.
I like how you've put together, and it really might almost be a vision both for the college and then for the field, because what you've talked about are all the core elements of what we do in public health. But I don't think people look at MCH that globally, because when you talk about, you're talking about MCH epi, for instance, we need the data, but you also need the HPM people to say, how do you use those data and then the economic data and put that together and say, this is what's going to save us money, or here's the most cost-effective way of doing that. And a lot of what you're talking about, too, is we really need to do things smarter, because our resources are going to stretch. I mean, in this economy, they're going to stretch. And so how are we going to use the Affordable Care Act, some of those prevention issues? You need all those elements in public health and in MCH. And the bottom line, and I think that's the theme that you've talked about the whole day, is that you've got to put people in the same room to do it. You've got to build coalitions, and you've got to get people, you need to know who to talk to. You've talked about the influence of policy. You can't do any of this without policy. So really you're talking about all those elements together, instead of, training MCH professionals to be health educators or epidemiologists or economists or, public health nurses, MCH nurses. That's a group that you really want together, talking about how you do that in a global way. I think that's sort of public health in a nutshell. I always hear people say that, and you know this better than I do, MCH, like public health is MCH. MCH crosses so many elements of delivering public health. And what you're talking about is that it's really a very global approach.
Yeah, 60% of what the average public health department does every day relates to MCH.
Yes, that's it.
And in some schools it's hardly even there.
Right.
It really is, I think the heart of public health. And we haven't even touched on the environmental issues, like
Right.
The Love Canal kinds of things with abnormalities, the fact, international health, that there's no potable water for 70% of the world's pregnant population. It's all of those things are really important. But I think the hardest thing that I think we're solving, certainly in this college, is reaching out to other disciplines. MCH and public health can't do it all alone. There's, why did it take us so long? I'm so glad that Dr. Petrola is head of health policy and management. Why did it take us so long to integrate mental health into this? Mental health is a huge part of MCH.
Right.
Look at depression, especially.
Right.
But so the MPH really needs to have a big mental health component in it, because community mental health is another really tough issue. One of the ways we got some unique things done in Gainesville, even though I don't have an MPH, I did not have formal public health training, but I almost always worked in all the different areas except environmental health. And so I was, in a way, self-taught. And but at the medical school in Gainesville, we did not have a public health group there, but we worked closely with all the health departments. Obviously, we brought in anthropology, health anthropology,
Right.
the psychology department. You know, it was unusual for the medical school to have anything to do with the undergraduate campus,
Right.
with the non-medical campus. It's not undergraduate. But, you know, with physical education, I mean, we found so many people to partner with. And then when we got a provost there who was an expert in AIDS, he brought all the colleges together on campus and said, you know, we have an AIDS epidemic, and there's something that every one of you can do to help solve that. Fine arts, engineering, and made them really nervous. History, you know, talking about AIDS, oh my God. But it was Andy Sorensen, and you know, he eventually became the dean and eventually president of the University of South Carolina. But a great public health mind from Johns Hopkins. And boy, that was the ultimate, is to take a whole big university, sit them down in one room and tell them, you're all going to work on the AIDS issue. And some of them really didn't like it, but it was brilliant, you know?
Yep.
And that's the way we got to be thinking.
Yep. Because you could certainly do the same thing with MCH.
Absolutely. You could go, you could think of every college on this campus. And the neat thing, you know, there aren't many universities in the country where health is on the same campus with everybody else.
Right.
And it's usually wasted.
Right.
And I think Dean Klasko's idea of, you know, pushing medicine, nursing, public health, physical therapy, pharmacy to all learn to live together and love each other is just, you know, wonderful. But then we all need to take that and get out to the rest of the campus too, because we have a great psychology department in this campus, and engineering and lots of other things we could be working on.
Business.
Yep.
All that.
Oh yeah.
All those things.
Yep.
Fantastic.
Yeah, business could really help us work with health policy and management on, you know, how do you keep a hospital and health departments in the black, but still not do things that are unnecessary, you know?
Well, do you have any other thoughts? I think this has been, you know, as we're talking, I can really see sort of pieces of this being edited, so you would look at sort of elements of MCH and how that can all fit together. And then I see this whole other piece, a real theme with you working through this is this idea of coalitions, that probably one of the strongest things we could do in the field of MCH is to start thinking, and I think we do intuitively, because you wouldn't be in it if you didn't think that way. But you know, one of the stories that you tell is you go out and you find those people. You know, it's not like it suddenly pops up from the ground all of a sudden. You go and you identify the folks that are already engaged. And you know, in the college, when you became the dean, you're right. You have to go out to the community and say, how are we meaningful to you? You know, one of the best stories I remember with that East Tampa initiative is Kay Perrin came back from doing a focus group in East Tampa. And she said, nobody's getting this. One of the things that somebody said in East Tampa, but it made so much sense to me intuitively, is they asked these folks, you know, that East Tampa was a desert. You know, there's no public transportation, no pharmacies, no grocery stores, no anything. So to do anything, you know, you had to travel forever to get there and try to get back. So, you know, public health goes in and says, what would you like in East Tampa? And somebody said a Starbucks. And Kay, you know, who is public health, absolutely got that instantly. And what she told me later was how many people thought that was the dumbest comment they ever heard. But I think that makes all the sense in the world, because if you had a Starbucks in East Tampa, that means East Tampa would be like every other place, you know? I think that makes a lot of sense. And the thing is, with us reaching out and saying who are the folks that want to be engaged, and then more importantly, you know, the community needs to tell us what they want. So instead of going top down, tell us that you want a Starbucks. I mean, I thought that was a great story, you know. So I can really see part of this interview being editing those pieces of what you've done where it's always we did this, we figured out, you know, here's the problem now, who needs to help us solve this? I think that's going to have to be our future.
And it's really hard. One of the reasons people don't do it is it's hard.
It is hard.
And it's scary. And if you're an academic and you've never done that, you go out and they'll eat you up, you know. And when I was at the Community Health Center in Minneapolis, it was primarily an Indian community, but there were some black families that lived there and a few Hispanic families and others. And we had they're all obligated to have a community advisory board of honest to God people from the community, not,
pretend.
But once a month we'd have a community advisory board meeting in the evening. And we'd have food for everybody and everything. And the staff was asked to come to those. And I might have been up all night the night before and worked really hard that whole day seeing patients. And then we'd have the community advisory board meeting. And it's really hard because people come in, and if you want to give people the chance to air themselves, sometimes you'll get people that are community activists, and this is back in the 60s and 70s, where people were raising hell about a lot of stuff. And you might be there till 2 in the morning with somebody just blathering on. Well, I call it blathering, but they felt it was important to, but I'm thinking, oh God, I want to go home and go to bed. And yet that was really important for building trust. We would change the way we ran things. We'd have to fire people at the front desk because they were mean to people. And often they were meanest to people in their own family. And so it's messy when you get out in the community.
It is.
It's hard, but if we're really going to make serious change, public health has to do a lot better job of that. I think we're gradually waking up to that. Our college recently was honored for having a great distance learning program. We started that back in 1996. We were the first one in the country, and all the other schools, all the other deans said, that is really stupid, that's not going to work. And now every one of them does it.
That's right.
And that's another way to reach out to the community. And I would hope, I don't know whether we're ready to do this yet, but MIT put every one of their courses, all their lectures, all their presentations out there for the world. Anybody can take any MIT course they want. Now, if you want credit for it, you got to pay. But the knowledge is out there, and I think schools of public health ought to do that too, and just put it out there on public TV or the open channel, and just say, if you'd like to take a biostatistics course, that'd be a thrower. But I think we need to be open and sharing with the community, and just much more community involvement. Bob Jackson, I think his name is. It's a black banker here in town. He moved here. He had prostate cancer, and he came to me. I was just starting as dean, and he said, I really want to work with men in the black community because prostate cancer is a big deal. And he said, do you have any faculty that can work with me and students? And I couldn't find anybody. In fact, there weren't any faculty interested in that. I said our students at the time were almost all people that worked. Now it's quite different.
Right.
And I said, they're just not available to come and volunteer for a lot of stuff because they're working all day and they're coming to class all night. He got a little upset with me, and I said, well, the one thing we can do is let you use the college. So anything you want to have, we'll
Right.
host it here. So he sort of advertised around the community, the black community in East Tampa primarily, that he was going to have an educational thing for black men as to what they ought to do to prevent prostate cancer. We opened up our auditorium on a Saturday. He had 700 people come the first time he did it. Well, what a shame that, we couldn't have had somebody loosen up some time to deal with that, because obviously he knew the community, he knew the need was out there.
Right.
And there are things like that that happen that you realize we're only touching the tip of the iceberg.
Right.
We could be doing so much more, and we need to constantly, and I know we are, constantly change the way we're teaching and training people to do new things. And that's why I've always said I thought social marketing was one of the biggest breakthroughs in public health.
And
Because we actually asked people what they thought would
want,
work.
yeah. That and things like, you're talking about what Eric's doing, for instance, using technology and social media and the internet. That's another area. And I think we've been very good in the college about staying up with those sorts of techniques. Because that's the other thing is, it has to be meaningful. Now we have this new generation.
Oh yeah.
That's a group that you have to reach as well. So.
And look at how President Obama used that.
That's right.
And
that's right. So, I don't know how to thank you enough for coming in and doing this. I think this is just going to be invaluable. And the thing about this being an oral history is you're going to talk about it, Donna's going to talk about it, Howard will come in, it'll live out, we'll put those threads together, and it'll be exactly like what you're talking about. Then we're going to put it out there, and anybody can listen to what you have to say. And I appreciate you doing this, Charlie.
that's great.